Welcome, everyone. We're thrilled to welcome you here today. I'm Robert Klitzman. I direct the Masters of Bioethics program here, and we're honored and delighted to have a friend and colleague, Dr. George Hardart, talk to us today. He is an associate professor of pediatrics and bioethics in the division of pediatric critical care. He's also director of the program in women and children's bioethics here at Columbia. He's a faculty member in our bioethics program. He's written widely about these issues, ethics in pediatrics. He was the chair of the Pediatric Ethics Committee here for a number of years and is one of the leaders in the field nationally. We're delighted to have him talk about a case. We have a number of people who are also joining us online. So people who are joining us online, welcome. And if you have questions, please email them and we'll have a chance during the Q&A to include your questions as well. So without further ado, please join me in welcoming Dr. Hardart.
Thank you, Bob, and good afternoon to everybody. I'll try not to be distracted by the ethereal presence of people outside the room, but it is a little distracting. In the title of my talk, I couldn't help myself from putting the Gold Foundation's Ethics for Lunch, because over a long period of time here, the Gold Foundation did support a series of Ethics for Lunches, and it really has gone away for several years. So thank you very much to Bob and the Masters in Ethics program for resurrecting it. I think it was always a great program. So I am going to present a couple of cases, and they're going to be essentially in the area of pediatric palliative care. They're real cases, they're interesting cases, and they're particularly relevant to us right now, since for a year or two we've been without a pediatric palliative care service, which the institution is working to rectify that situation, but perhaps it's a little more reason to focus on palliative care issues as an institution until we get that online again. So I want to move quickly through the cases so that we can get to discussion, because discussion is really what makes an Ethics for Lunch work well. The ground rules for today's session: I have substantially changed the details of the real cases, because really this is not at all a confidential forum, and these are real cases. So they're very materially changed, and so it does detract a little bit from talking about the details of the case, because the details of the case do make ethics much more real and worthy of discussion, but it's a necessary thing to do. Audience participation really is strongly encouraged. I'll be saving it hopefully for the last at least 20, if not 30 minutes of the session if I get through my slides adequately. So really it is welcome, and the way to view it is you're the ethics consult team in these real cases, and how would we approach them as a group if we were going to be confronting them. And please, just as always, keep this a very constructive comment and mindset zone. So the first case, and I'm going to go through two cases, two vignettes, raise some ethical questions, then go through some background. So case one is a 2.5-year-old boy with an undiagnosed genetic syndrome. Probably it was a slowly progressive neurodegenerative syndrome. Cared for at home by a loving family for most of his life, although he had frequent hospitalizations. Was nonverbal, non-ambulatory, had limited relational ability, wasn't super interactive. And was beyond that, had some intermittent irritability for unclear reasons, of course unclear reasons, because he's a very youngster. Was fed by a gastrostomy tube, but didn't require any other medical technology, required no respiratory support at home. So he now is admitted to the pediatric ICU for RSV pneumonia, which is RSV is a common wintertime virus, but it can make people very, very ill, and also a bacterial urinary tract infection. So it gets moderately ill related to these infections, to the point that he does require the placement of an endotracheal tube for mechanical ventilator support. And the ICU course doesn't go super well. They attempt to remove the breathing tube, get back to regular breathing. At 3 days of age, that doesn't work, and then they try again at 11 days into the ICU stay, and that doesn't work. And it becomes relatively clear to the healthcare team taking care of him that, that it's going to be very difficult to get him breathing on his own again, and that he should probably have a tracheostomy tube placed in his neck for long-term mechanical ventilation and respiratory assistance. So as that's becoming clear, this really wonderful family who has been caring for him and thinking about what's best for him for a long time comes to the conclusion that they don't think he should get the tracheostomy tube, and that if he were to not succeed with extubation again, that he not be reintubated, even if that were to mean that he would die. And an ethics consult is called in this situation just to assist with decision making as things go forward. So the parents, what we know from this is that they don't want him reintubated if he fails extubation. So in this sort of de-identified real case, this is a busy slide, but it's sort of intentional. There were a swirl of ethical considerations that the healthcare team were thinking about as they were trying to figure out next steps, what to do for him. Just say for both of these cases, in the end of the day, everyone agreed that the medical care delivered to both of these families that I'm going to talk about today was terrific. So there's not as if there was some kind of major conflict in either case I'm talking about, but there were many ethical questions. And it really is as if people felt as if they weren't standing on solid ground. It was difficult to find their moral footing in justifying what the next steps were. So, and we're going to go through some of these questions in the discussion. But how just in general do we approach decisions like this, and how do we justify them? When I was beginning in ethics, one of the first things I learned was the real purpose of ethics is to justify our actions. So whenever we approach situations like, especially weighty ones like this, how are we going to justify our actions is a key function. When the healthcare team has to think about this, they're going to try to extubate him again. How are they going to approach that? And how will they justify their approach beyond that? There were a couple of quite different approaches that were considered at the time, one of which was to start a morphine infusion on him, stop all treatments, turn the monitors off, extubate him without oxygen or any kind of support at all, and place him in his mother's arms, his parents' arms, with the full expectation that he would pass away in fairly short term. Another approach that was considered was to place in the orders a do not attempt resuscitation order, to proceed carefully with extubation, maximize his chances of getting back to his pre-hospitalization condition, all the while honoring the parents' wishes to limit life-sustaining treatment and intubation and chronic ventilation. Quite different approaches being considered, and how do we make those decisions? How do we justify them? What is the intention of the extubation? This was something that was debated. What are we intending? Are we intending his death when we take the tube out, or are we intending to remove unwanted treatment? And tied in with that somewhat, what do we do with these medications like morphine that might suppress his respiration and accelerate the dying process? Are they morally justified or not? And how does withdrawal of nutrition hydration enter into it? This is a boy with a gastrostomy tube who's dependent on medical nutrition hydration. Should those be limited? Should they not be limited? Where does that fall in the decision-making process? So those are the sorts of things we're going to come back to with that challenging case. So the second case is a 6-month-old with cardiorespiratory failure, quite critically ill in the pediatric ICU also. She is a youngster with a somewhat similar background. She was born premature, has a probable genetic syndrome, has had significant complications of prematurity, has significant chronic lung disease, which is a complication of prematurity and makes breathing more difficult and more likely to need oxygen and respiratory support, and has a condition called pulmonary hypertension, which at the root of it is a problem with the lungs. The lungs have not developed normally, but what it means is that the blood pressures that the heart is pumping to get through the lungs is very high. and really the consequence is the heart fails. So pulmonary hypertension is in some ways a heart disease, and there's chronic lung disease as well. And very commonly these two, particularly in combination, can be very, very severe problems to have. So she has been hospitalized for virtually all of her life. It's been a pretty rough road for her and her family. And she's had significant growth failure, and it's only really gotten worse with time. She did additionally undergo cardiac surgery at 2 months of age for a VSD, a ventricular septal defect, which is a hole between the main pumping chambers of the heart, and coarctation of the aorta, which is a narrowing of the main artery coming out of the heart. The hope was that this would improve her condition, but it really didn't, and her lung and heart disease only progressed. So she's had a pretty long, complicated ICU stay. She's had additionally multiple cardiac arrests. Her heart has stopped, requiring major resuscitation several times. This, of course, means that she's pretty darn sick. It also means that she could have some neurologic complications of those cardiac arrests. It's unknown how severe it is because she's needed to be very sedated with muscle-relaxing medicines, and so it's unknown kind of what's going on underneath. But additionally, she's on those sedative and muscle-relaxing medications, paralytic medications, and is quite ill. One estimate of her prognosis is that she has at least a 60% chance of not making it out of the ICU. But there's a great deal of uncertainty acknowledged by the medical team in this circumstance. So also very loving parents, very devoted to her. They want her to survive. They want her hopefully to lead a normal life. But they're very troubled by the suffering she's enduring. And they're struggling about what to do, what the best things are to do for her. One aspect of this is the healthcare team really feels like that they will follow whatever recommendations they make. And that is making the healthcare team feel very, very responsible for any decisions they might recommend to them in this challenging situation. So again, an ethics consultation is called. Similar ethical questions were raised, which is why there are some similarities between these two cases. There are a few typos in the first section here, but it's because it's identical to the first case. How do we justify our decisions in this circumstance? But some specific questions that related to this case were, what should be recommended to the parents? What should be offered to the parents? And how are those things different? How about a heart-lung machine? She's already pretty sick. What if she gets sicker? Will we put her on a heart-lung machine to try to help her through? What about more chest compressions and shocking and resuscitative medications, CPR? Would we continue to recommend those? Would we continue to offer them? How would we handle that with the family? What about the ventilator? Would we recommend stopping the ventilator? How would we try to define some limits related to that? And what about nutrition, hydration for her? All these questions were swirling around the medical team's thought process. And what do they focus their decision making on? Is it the suffering she's enduring? Should that be the focus of how decisions are made? Or is it more the possibility of her having a chance to get out of there and lead a somewhat normal life? Where should the focus be? Where the medical team felt like, are they giving up on her if they were to limit treatment in some way, to extubate her? Would that be taking away the chances of this person at very early stage of life with the great plasticity that babies sometimes show us? If extubation is pursued, the baby's needing those paralytic medications, would those be stopped beforehand? Certainly if you left those on, it would be less stressful for the family, because sometimes the dying process involves some very awkward looking breathing by a dying person. Would it be okay to leave those paralytic medications on? So a lot of questions swirling around this case as well. So we're going to come back to those. I will sort of reframe them for you. I'm going to try to go quickly through some basics, some background of ethical decision making in pediatric palliative care. So these are the broad topics of the things we're going to go through. I won't labor over them because we're going to get back to them as time goes by. One of the main aspects of pediatric palliative care, or palliative care in general, are discussions of the goals of care. I have to give a disclaimer. I am not a palliative care specialist in any way, shape, or form. I'm an intensive care physician and an ethicist. Just understand that when I talk about palliative care, it's as a non-specialist who's doing his best to convey the way it is. But there are ethics related to the goals of care, and that's why I'm going to talk about them now. One major, it's a pet peeve of mine. I have many pet peeves. One of them is this concept of withdrawal of life support and withdrawal of care. It's very common that those two terms are used synonymously, and in my opinion, they very strongly are not synonymous. We will withdraw life support technology, but we never withdraw care. It's a super important distinction, honestly, because families and patients greatly fear abandonment if they allow discontinuation of aggressive treatment. In fact, there are a lot of old studies that show that, in fact, they get less care. They measured the time spent with patients once a decision was made to make somebody DNR. And very sadly, they saw that doctors and nurses spent less time with families after that decision was made. So families fear that abandonment, and it's shown that doctors and nurses can respond in that way. The palliative care movement has certainly shown that these patients, they need us not to step backwards away from them, they need us to step forward and provide more care for them in these circumstances. So, it's just terminology, but the terminology matters, and we don't withdraw care, we withdraw life support in proper circumstances. And what we do in these circumstances sometimes is redirect the goals of care. Usually in hospitals like ours, we just think about the goal of care being to cure. But sometimes we need to change those, shift those goals to a more palliative mindset. We think about this most in terminal cases, people who are dying, and therefore focusing on comfort and time with family and end-of-life tasks. But it isn't just those circumstances. It's also people with chronic diseases who need their symptoms palliated. That is a prime role for palliative care specialists as well. And we always have to remember, as we're redirecting these goals of care, there's a moral dimension to them. Is it time to redirect goals of care? Is it time to limit treatment? There's moral dimensions to that both physicians and patients and families have to consider. I pirated this graphic from Joanne Lin, who is really a giant in both the palliative care and medical ethics. And I find it one of the most helpful images to keep in mind when thinking about the ethics of palliative care and palliative care in general. And you can just see there's a continuum of care. Now, on the x-axis there is time, as Dr. Lin did it, but I'm not sure we need to limit it just to time. You could put a number of other variables on the x-axis. But you can just see that curative care and palliative care, they coexist. Early on in the course of an illness, maybe early on when the prognosis is still good, when the symptoms are not so bad, etc., we're focused more on curative care with some degree of palliative care. And obviously as things change, conditions change, the focus can change, and we can focus much more on palliative care than we do on curative care. One aspect of this you need to just think about is that different treatment options will mean different things and have different value when you're at a different point on the continuum. CPR, for example. Perhaps early on, when prognosis is very good, well, CPR may be desirable, even if there are some burdens associated with it. If your chances of survival long term are good, then heck, maybe that may be really desirable. Once you get to the very right side where maybe the prognosis is extraordinarily dismal, then CPR has a very different value overall, doesn't it? So different treatments can mean different things at different times. The landscape can shift on us. The other part about children is that an adult, somebody with capacity, they can refuse any treatment. And that's ethically based in the principle of autonomy, of course. Whereas with children, particularly young children, we're not basing it off autonomy. We're basing it by the best interest standard. And so, whereas an adult can just say, I don't want CPR very much at the left, and it's very much determined by their wishes and preferences and values, it's a little bit different. And we're always using the best interest standard with children, which makes it somewhat more complicated. So a little more on goals of care. It's best if they're made explicit. I'm going to move somewhat quickly through these slides because I want to get to discussion. So there's art to this. When you are redirecting the goals of care, it's best to focus on big ticket items. Focus on what the overall goals of care are and those things that people are very aware of, like CPR, like intubation. For the little things, it's best not to, unless families want to talk more about every little detail, it's best not to focus on that because it can just in fact be more burdensome to focus on details up front than it is helpful sometimes. It also means, particularly with children, when we're using the best interest standard, that treatment limitations aren't as clean as some of us in medicine want them to be sometimes. Kind of an old school way of thinking about it is DNR meant you didn't get chest compressions, you didn't get the intubation, you didn't get anything. It was an all or none phenomenon. Whereas there's been a shift. We now know that different treatments, even different treatments that would be incorporated in CPR, so-called resuscitation, have different potential value, different meaning to patients and families. So it may not be as clean as some in medicine would like it to be. But really, if you have excellent communication with families and you really have a good understanding with each other what the goals of care are, it can, in a very good way, streamline decision making. Maybe for the sake of time, I'll just focus on the part of it that says communication, 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 because it is really a key part of ethics consultation work in general, and certainly in weighty circumstances like decisions these consultants were dealing with. The more communication, the more explication of values and wishes and preferences and meaning, the more the better for sure. Information needs to go both ways. We need to learn what families think about various treatment options and what various outcomes would mean for them. We also need to provide them with a lot of information about what to expect. Not just prognosis type information, but let's say you do withdraw the ventilator. What will that look like? What's it going to happen? What's going to happen? What can they expect? Because they've never been in this situation before probably, but we have. And those sorts of things make a big difference in good care of patients, families. Moving on to decision making. I hope many people in the room know about the concept of shared decision making. It shouldn't be a foreign term. It really shouldn't be a term that needs definition. But in this post sort of autonomy era, it's an important concept. The idea is that in shared decision making, it isn't just the patient and the family that makes decisions. We don't just offer them a list of options and say, you pick now. That we have a professional and a moral obligation to be very active participants in that. Franz Engelfinger long ago had more than one famous quote, but this is one of them. A physician who merely spreads an array of vendibles in front of the patient and then says, go ahead and choose, it's your life, does not warrant the somewhat tarnished but still distinguished title of doctor. So that pretty well encapsulates what the general idea of shared decision making is. We have a great deal of responsibility in helping recommend options to patients and families to help them understand the situation. And it's uncomfortable for some doctors. It just is. It's easier not to be responsible for making such decisions and saying, no, you have to do this. Doctors are sometimes very uncomfortable with prognostication. When we don't know, it's easier to say, I don't know what the outcomes are. But we're always making decisions under uncertain conditions, always. It's part of medicine and healthcare. And we can't abdicate that responsibility to help with that prognostication because patients need it, families need it. Then, when you don't know, you may not know, but the prognosis may be good. Maybe the prognosis is, to put numerical values on it, maybe it's 40 to 90%. And you say, I don't know what it could be. It could be, I don't know, it could be. But it's important qualitatively for somebody to know whether that area of uncertainty is right on the good side of prognosis or the poor side of prognosis. To just say you don't know is unfair to families. We need to be comfortable with recommendations. A couple of other points. I'm not going to focus on withdrawing and withholding because it's not as relevant for today. I will mention some things about medical nutrition hydration because they were relevant to these cases and does come up in medicine, in limitation of life-sustaining treatment. And very clearly there is, in society and the law, there is a consensus that medical nutrition hydration, tube feeding, tube hydration, are medical treatments that patients and surrogates can refuse. And that's back from the early 90s when the Nancy Cruzan case was adjudicated. This applies to pediatric patients as well. It's a medical treatment. It doesn't seem like sometimes like a medical treatment to us, but if you think back 100 or 200 years, the idea of being able to create a tube and nutritional supplements that could provide nutrition, that's actually pretty high tech. So these are absolutely medical treatments, and medical treatments are subject to judgments about their benefit. So even though it's pretty clear to those of us in ethics that nutrition and hydration are just medical treatments that should be treated the same as everything else, the public doesn't always feel that way. And doctors don't always feel that way, particularly pediatricians. For some people, they're troubled by withdrawal of nutrition and hydration because they seem so basic and so ordinary. Pediatricians have been particularly troubled, as have in many circumstances parents, because there's some special meaning in pediatrics. All infants need assistance with feeding. So it's always artificial on some level. So to remove that isn't just removing some technology, it's removing what we normally do for infants. There's also just the meaning of feeding in parenting. The whole notion of food is love. And if you are going to withhold food from your child, are you withholding love from them? There's a lot of meaning there that goes beyond just a medical treatment. Another aspect to it is that when you withdraw a ventilator from somebody, take our second case, CD, perhaps if the muscle relaxants aren't on board. When you take the breathing tube out from somebody, it's probably pretty likely if they're very ill that they're going to pass away from it. But there's a chance they could breathe. There is that chance. And otherwise, you're letting nature take its course, the disease process take its course. When you stop artificial nutrition hydration on somebody, it may take a while, but there's only one outcome. If you choose to not provide that, there's only one outcome. So it has a more moral weight in that regard. And the final thing is that usually, not always, but usually, tube feeding is less burdensome than CPR, ECMO, mechanical ventilation in an ICU. And so in that shifting framework of where the burdens and benefits are meeting, it's going to generally be less burdensome. And so generally, less likely to argue for discontinuing. So yes, it's a medical treatment, but also yes, there are morally significant differences between that form of treatment and others. I've kind of already gone through this. We could talk about more. Very briefly, anytime you talk about palliative care ethics, you need to mention the doctrine of double effect, because it really is the ground for how we make decisions at the end of life. And the general idea behind the doctrine of double effect is that when you're going to consider an action that has two effects, like the provision of morphine or the removal of an endotracheal tube from somebody, if there are two effects, one that is good and one that is bad, there are some rules that should be followed to make sure that it's a morally acceptable act. And they're listed here. So the act itself should be morally good or neutral. If you're trying to achieve a good effect of relieving suffering by shooting somebody with a gun, for many people that would be considered not a morally neutral act. Whereas giving morphine to somebody is a morally neutral act. So then the act itself should be morally good or neutral. The key factor of this, and a very key factor in all of what we do in end-of-life care and in medicine, and in ethics is your intention. This is actually a thing that's debated, whether or not intention should be something we worry greatly about, but it is, I believe, still a core part of moral decision making. The idea that the good effect is intended. You foresee that if you give somebody a good amount of morphine, it could potentially accelerate the dying process, but you don't intend that. If your intention is the other, then according to the doctrine of double effect, it may not be a good action. The bad effect is not a means to the good effect. That's a key feature. So if somebody is suffering and you give them potassium, a big dose of IV potassium, you will relieve their suffering. But you will be relieving their suffering through active killing, which may be concluded to be a bad means to a good effect. And then proportionality is a key part of life, medicine, certainly ethics, and that the good effect must outweigh the bad effect. If you take a child with, who has appendicitis and they're having pain after their surgery, you wouldn't say, I'm going to give them as much morphine as they need to have no pain whatsoever, because that's a key thing that I need to do. Even if they die, I need to treat their pain. Well, that's not very proportionate, is it? You're going to do things differently in one circumstance versus the other based on proportionality. I'm feeling the need to get to discussion. So I'm going to go through neuromuscular blocking agents. I just went past them. In the second case, neuromuscular blocking agents are something that we use commonly in the ICU, but if you're going to withdraw life support from somebody, there's a fairly clear moral rule among critical care physicians that they will be stopped before withdrawing life support. For one thing, we get to that situation of there being only one outcome. If you've made it unable for somebody to breathe, you're not making it a natural event when you take the breathing tube out. But also, maybe more importantly actually, you may be masking suffering. You may be masking symptoms as you take the breathing tube out. So there's a very clear rule that it should not be done. I went past the slide quickly for the sake of not talking too much about it. But despite that, and usually for the sake of making it easier on the family, critical care physicians historically have done that not infrequently, have taken breathing tubes out with it. And that's a morally discussable thing to do. What should we do for the sake of the family's comfort, which is obviously a pretty good thing to focus on, but that might have significant impact on the patient. So maybe I think the final slide before we have some discussion is the role of the family and family interests in decision making. This is a big focus, a big background issue in every day in children's hospitals. And Nancy Berlinger from the Hastings Center, who's done some wonderful work in pediatric palliative care, she encapsulates one aspect of this in a nice way. The values of family-centered care, a primary goal of hospitals like ours, should not slip into treating the parent or family as the patient. This obscures the patient's identity. So it remains a key thing that we do to try to make life easier for the family because we're caring human beings and because it helps our patients as well if we care for the family. But we do need to remember that our primary fiduciary duty is to the child, is to the patient. And there's a history there too, because while quality of life judgments are moral considerations that should be applied every time, we've got kind of a not great history in that regard. There's a history that patients with disabilities, when we have made judgments assuming what their quality of life was, we have pretty reliably underestimated what they consider their quality of life to be. Short version, a Duchenne's patient, a Duchenne's muscular dystrophy patient, somebody with significant neurologic disease, we might say, that's a terrible quality of life, I never want that. Whereas if you ask them how's their life, they say, yeah, pretty good, about the same as yours. So both families and particularly doctors have a pretty bad track record, and we need to be conscious of that. Always look at things from the patient's perspective, and remember our fiduciary duty is to their best interests. Okay, let me just go back to our first case. I'm not sure you guys remember it, but that's the 2.5-year-old who's hospitalized with RSV pneumonia, and the parents have decided that they don't want to pursue tracheostomy. They want to redirect goals of care to not pursue chronic ventilation, even if it means him passing away. And an ethics consult, it's called We're the Ethics Consult Team. So if you want to ask some questions, please feel free about the case. If I can either tell us a true part of the story or make something up to keep it away from the real case a bit. But then, or if you want to just take on any of the questions on the list there, please feel free. Or I'll just start asking you guys questions. Yes?
I'm just curious if the parents, are they just at the end of their rope? They've been doing this for 2.5 years. They've gone through a lot of up and downs. Is there something different about this particular moment?
So the question is, how did the parents get to where they are now? Are they just at the end of their rope? What has occurred to get them here? I think that the short answer to that is they had a palliative care consult a while back. It's been on their mind. In the same way for the second parent, the suffering that their child's enduring and the benefit that he's getting from treatment, it's been on their minds a long time. And yes, this is a fork in the road for them. The idea of the burdens associated with long-term ventilation for them, they don't think that that's in this little one's best interest.
Whether or not the parent's decision is appropriate and ethical for the team to follow through with, or just like how they're going to fulfill the parent's desires in this case.
That's a good question. So what is the purpose of the ethics consult? If it seems like a justifiable decision and the parents have the right to make that decision, why get an ethics consult? Because I'm an ethics consultant and I want work. No, interestingly, it's kind of changing now, but in our hospital, in New York Presbyterian writ large, the rule has been for many years that all withdrawal of life supports require an ethics consultation. It's sometimes, for the reasons you mentioned, it's sometimes a rule we haven't followed religiously. But in this case, it was because it really is required. But the other part of it is there are substantial moral dimensions, and a lot of, even if it's a completely justified decision, to redirect the goals of care, to decide not to reintubate. There's additional benefits from ethics consultation to help healthcare teams operationalize that in the most ethically sound manner. And also, these situations come along with significant moral distress for healthcare providers, doctors, nurses, allied healthcare workers, and for families. And if we can serve the role of reducing moral distress, which hopefully we can sometimes at least, then that's a valued role also. So what do people think? What would you recommend? If you just look at that list of, how do you think the next extubation should be managed? You have those two options that were discussed, and this kind of goes to that. I think the healthcare team there wasn't unanimity in what's the most morally sound way to move to the next step. Should we put the kid on enough morphine that there's no discomfort related to taking the breathing tube out, turn everything off, and extubate to the mother's arms, or try to honor those wishes by give the kid a best chance of getting back to that pre-RSV pneumonia condition of being home, being on tube peds, being with the family. Honoring those wishes, but trying to operationalize those best interests in that way.
Well, it seems that the second and third questions might be reversed. And we often ask, especially parents, what do you want to do? And the question is, what do you want to happen? So when we're talking about extubation, as you say, what's the goal of extubation? So prior to understanding the goal of extubation, we can't begin to see and plan for how we want that extubation to unfold. Yeah. And I think it's always important to recognize, especially with very young children, that parents' pre-birth expectations for their children have been interrupted by the reality of the condition that their children are born with. And that a lot of what unfolds in these early days and years is coming to terms with the reality and then being able to say, how do I imagine my child's life given the current realities? Yeah. So I think we want to talk to them about what do they imagine the future will be, or is the future they're imagining the end of their child's life?
Now, those are excellent points. I mean, I heard kind of two things in there. There's an absolute fact that when there's a major quality of life change that occurs, whether it's as a parent seeing there's expectations change when you determine your child has an important medical condition or you have an important change on your own, there's a period of adjustment that occurs. It's a really important part of parenting. It's super, super common in the neonatal period for parents when their kid has a life-limiting condition or just a life-altering condition. Quality of life change. Down syndrome is a classic example. Parents can immediately have a feeling, there's nothing universal about anything, but go through a period of great mourning and a desire to redirect the goals of care. When time occurs, and again, I don't want to paint with too broad a brush, but it's just a very common scenario that with the passing of time, things change dramatically. And that idea of redirecting care would be anathema to that parent. So the coping, the adjustment that occurs psychologically is a super important part of quality of life assessments, both for individuals and for parents as well. The other part is when you get a vignette like this, I gave you completely inadequate information to help answer that question, didn't I? What are their wishes? You need to know more. Why do they want to not reintubate? What are they worried about? Is it more than just not wanting a ventilator? It's that they believe for the last year he's been suffering deeply, and they are very concerned about that chronic suffering. You need to get much more into the weeds, understand what they're thinking about him, because they know him much better than we do. What are their values, and what do they see the future? And then get into that shared decision-making mode to try to help them understand what may come with various paths and what are they hoping for him in the future. Yeah.
This may be a bit off the subject. However, what if a child or children have been neglected and whatever may have started as a flu or a simple diagnosis due to the parents' negligence, either physically or psychologically, the children have been at risk. How do you address that?
That's a good. So the question really, if parents have done something through negligence to get their children in a bad way, I suppose, what does that mean to their status as a valid surrogate decision maker? For the child. It's complicated. It really is. This is not a theoretical question you ask. This sort of thing comes up not infrequently. I think honestly, what we try to do is honestly understand that people are human and mistakes are made, and it may legally limit what they can decide for their children. Okay, there's that element. But if the authorities don't remove decision-making power from them, we, within reason, try to keep them involved in, even if they've made mistakes, try to engage with them in a way, especially in circumstances like this. You try to, within reason, within the law, to keep them involved and still try to make best interest determinations for them with their values. But it's a very good question and a very real question, unfortunately. A big part of the discussion in this case was the nutrition and hydration. And when we take the breathing tube out, should we just tell the family we're going to stop nutrition and hydration as well? I didn't know if anyone had any thoughts about whether that should be a part and parcel of the whole withdrawal or whether that should be treated differently. Go ahead.
When I saw that, I thought, what does that have to do with extubation?
Yeah.
I thought that regardless of whether or not the tube is being removed, the child should still be well nourished. But maybe.
No, that's a good question. What do the two have to do with each other? Extubation or withdrawal of nutrition hydration? I think that was something that the medical team dealt with also. I think it is true that if you're putting limiting treatments on the table because you've redirected the goals of care, they are, like we talked about, they are both medical treatments and they both could be limited. But I think, as I kind of pointed out, there are moral differences that are important. And I think in this case, what in fact the medical team did was they didn't make that part of the discussion or part of the plan for the child. It was more to do what the parents wanted, to remove that burdensome, unwanted medical treatment, the ventilator, and otherwise try to attend to comfort and take care of the family and take care of the child in the meantime. So I think your point's very well taken. Go ahead. Oh, you're no, please. I'm not sure. I don't want to leave case 2 without a chance for having any question or discussion. We just have 5 minutes left. Good. It's actually good timing. But case 2. So this is the youngster who the medical team is really struggling with. Has had a very long road. 6 months. Most of the 6 months of her life has been in the ICU, mostly going the wrong direction. But there's a lot of uncertainty and a chance the kid could come out of it with long-term good outcome, even though there's been an enormous amount of day-to-day suffering for the child and the family as well during it. And the medical team feeling like there's been enough suffering going on and enough hardship that decisions should be made, considered to redirect care because concerns are bubbling about the ongoing suffering. First off, if you guys have questions about the details of the case, please feel free. Go ahead.
So, if the purpose of removing or not offering treatment is to prevent the suffering of the child, why would the withdrawal of the medical nutrition and hydration be an option? Wouldn't that prolong? Like, I understand at the end of everything, the child would more likely die. But why would you withdraw medical nutrition and hydration? Wouldn't that prolong the suffering? Like, wouldn't it take longer for the child to die because of
I think, when I included this, included medical nutrition hydration, it was not a major part of the discussion for this child. Your point is well taken. But I think people, when they're approaching it, going back to what's the role of an ethics consult, the idea is that, healthcare providers struggle with, once you've changed the goals of care, is it now just a laundry list of what do you think we should not offer and what should you not? And I think as responsible healthcare providers, we need to remember Joanne Lynn's continuum of care and think through, what are the most burdensome things and think about limiting them first and think about what the goals of care are for this individual at this time and focus that way. And I think you're right. I think, if, for the medical care team, just in fact in this case, that idea of a heart-lung machine, they had already kind of taken that off the table, if you will, and said that would be, for the condition that she is in at this point in time, that would just be too burdensome and the benefits would be too low for her. And so that won't even be considered. So that was just the most burdensome, aggressive intervention that would have a long shot of benefit. And then things like CPR, that's often the entry point to redirecting the goals of care for the ICU. And that's a big hurdle for many families to come to say, even as poor often as the outcome is from resuscitation, that's a big hurdle to limit in any way what we want to do for our children to have them the best chance of making it out. And so that really is kind of an entry point to redirecting the goals of care, because that is pretty burdensome. And the outcomes aren't super. So the benefits aren't super, the benefits are substantial. So no, I think that really, the nutrition hydration for this piece, once you frame it in the right way of thinking about the burdens and benefits of various things and where the kiddo is, was a small part of this. Yeah.
I know you had mentioned earlier the role of nutrition, of the medically applied nutrition and via the tubes. I apologize, I'm not familiar with the term, as something that is an obligation on the parents for the nurturing and nutrition of their child and how that plays into the role of ethics. What are the societal ethical obligations towards the child if there are no parents or family in the picture where you're dealing with the treatment?
A very interesting question. That there's the legal doctrine of in loco parentis, where you would therefore continue to make decisions on the best interests of the patient. It's a much more interesting question than I think you know. Because parents actually parents have enormous discretion in making decisions for their children. You can even make decisions as a parent that aren't in your child's best interest, that are in some way against their interests. Like I always say, when I let my children stay with a 12-year-old babysitter, that's not in their best interest. But it's in my interest, and if it's in my interest and it's for the well-being of the family at whole because I don't go insane, then it's okay. But parents get great discretion to impose their value system on their children, and even sometimes to act against their best interests. When a healthcare provider, because in loco parentis, is making decisions, that latitude is gone. And you need to make the most objective, targeted, best interest calculations that you're able to do. Now, this is always going to occur with legal authorities involved to a certain extent, but the legal authorities in those rare circumstances will always defer to the doctors and nurses and ethics consultants, because you're the closest to them. You're in the position to make the best decisions for them. Good question. And let me just finish up with my, sorry for doing it this way, my finish up slide, and then I'm happy to take a couple more questions. Wow, this was an inefficient way to do this.
We're fast readers.
So, for me, the sum up slide for this would be, when making good ethical decisions in pediatric palliative care, communication is in many ways just such the key part of it. And what I often say in ethics consultation work is communication, effective communication between team members and with families and with patients often solves ethical issues before they even can get going. But focusing on the role of values, patient values, family values, healthcare provider values, they matter too, and societal values and law very much come into play. Part of that communication often involves eliminating labels, vague terms that are very unhelpful in decision making. Concepts like terminal or futile or do everything, ordinary. There are many, many poorly defined, vague terms that are unhelpful and can sometimes be used to mask our own bias in what we want to have done. So, as part of good communication is it removes those labels and makes us able to understand each other much better. A very deep and honest focus on the goals of care in proper circumstances is really the root of it all, and it clarifies, once you know what the goals of care are for a person, it can clarify so much what should be done next. Even though if it is, for hospitals like ours, we're built, places like ours, we're not hospices. We're built for curative treatment. It's a little bit unnatural for us, that shift to palliative care. Of course we do it routinely, but it's a big shift. And so making that happen in a most open, transparent way is best for all concerned, including healthcare providers and those that might be feeling moral distress. I often say in pediatric ethics, if you want to just know go to the end of the book and find out the answer to every question, it's always going to be burdens and benefits. So much of what we do in pediatric ethics is determine the burdens and benefits of various options. And the right answer is going to be the one that maximizes benefits over burdens virtually every time. And family-centered care it's a mantra. It's a key value of pediatric health care, of children's hospitals, and a very valued one. But we do always need to remember, and sometimes it gets a little lost, believe it or not, that the child should be the primary focus. That families matter deeply, but we do need to keep focus on that responsibility of ours, that sick child. Thank you very much for your participation.
Well, that was great. Thank you. That was a terrific discussion, many, many issues. And thank you all for coming. And we look forward to seeing you at a future event. And please join me again in thanking our speaker.